Hi, my name is Carrie Collado, and today I'm going to be talking about diagnostic imaging and osteonecrosis of the hip. So, what is osteonecrosis of the hip? It's also known as avascular necrosis, and this is a condition that happens when blood flow to the femoral head is disrupted. Without early intervention, this could lead to bone death. Early diagnosis is key. And so some risk factors are any past trauma that has happened to the hip, excessive use of alcohol, long-term corticosteroid use, and this could be people that are taking medications for asthma, rheumatoid arthritis, lupus, because some of these conditions are commonly treated with these types of medications. So that's just something to look out for. Smoking, males have a higher prevalence of getting this than females and between the ages of 30 to 60. So some clinical presentations. One of the biggest things with osteonecrosis of the hip is that the patients might not have any pain in the beginning stages. And so it basically starts as a gradual onset of deep hip, groin, thigh, or buttocks pain and stiffness. They'll experience pain with weight bearing, pain with hip internal rotation. They'll have decreased hip range of motion, and then they'll have antalgic gait. So, like how I said before, that they might not have any pain in the beginning stages, it's important to recognize the signs because treatment outcomes are directly correlated with the stage of this disease. Here is just the staging of osteonecrosis. So there's a 0 to 4, 0 being normal. Really about stage 3 is when we begin to see that crescent sign that we talk about when we're looking at x-rays. But if you look at the clinical symptoms, this is where we start to see where on stage 1, they have just pain, typical pain in the groin, then it's pain and stiffness. And as you can see, the worse that the condition gets, the more noticeable the symptoms become. So that's why it's pretty important to pay attention to the early signs so that we can prevent it from progressing. So for differential diagnosis, we could have hip OA, and this is typically in our older patients, older than 60, pain and stiffness in the hip, and that may radiate to the groin, pain with squatting, that morning stiffness, maybe some crepitus. What we might find in the imaging is joint space narrowing or maybe even osteophytes. And they're typically going to have that morning stiffness that lasts less than 30 minutes. Now, another one is hip labral tear. So here we're going to have the catching or clicking in the hip joint. It'll be worse with full flexion or full extension, and we'll see that C sign. For the MRI, we'll see a labral defect, and typically this can be reproduced with provocation tests, and it's usually associated with trauma or femoral acetabular impingement. It could also just be a hip stress fracture, and this is mostly commonly seen at the acetabulum and the femoral neck. And again, we're going to see activity-related groin pain. Pain worsens with weight bearing. We might have that female athlete triad. And here, the biggest difference that we're going to see typically is that on the MRI, it's going to detect as bone marrow edema with hypointense line on fluid sensitive sequences. And so that's that. So for osteonecrosis of the hip, as we saw before, this would be like stage 3 when we start to see that crescent sign. But in the beginning, the x-ray might come out as normal. Later stages will present as the crescent sign. And basically what the crescent sign is, it's an indication of a subchondral fracture. And what that means is that the bone beneath the cartilage has collapsed due to loss of blood supply. The bone dies and weakens and can no longer support the overlying cartilage, leading to a fracture. So this was the stage 3 that we saw earlier. It was also noted that the best view for this was frog leg view. It was found to be more reliable than AP view in detecting osteonecrosis of the hip. I was kind of confused before because I remember in class we learned that for a fracture or for a dislocation, we don't really want to use frog leg view. But after looking it up, it said that osteonecrosis in a non-acute, non-traumatic case like suspected avascular necrosis. There's no concern for unstable fracture. So the frog leg view is actually safe and useful. And as said in this study, it's actually more reliable than the AP view in detecting it. And so for our MRI findings, this is actually the primary indication for osteonecrosis. And what we found is that MRI can actually detect asymptomatic lesions of osteonecrosis of the femoral head before abnormalities on the X-ray. And for CT scan, it's not really normally used for this reason, but they'll use it to provide information for surgical planning, and it can help determine the severity and location of articular collapse. Some PT interventions. So in the early stages, what we want to do is try to limit the weight bearing through the affected leg. So we want to use a cane or crutch. We can do pain relief modalities, gentle range of motion. We just want to educate the patient on risk factors such as smoking and alcohol abuse. And we want to prevent excessive compression or shear forces. And for after surgery, if they end up having surgery, what we want to do is strengthen the hip muscles, improve the full range of motion, work on gait and balance, and just educate the patient on any post-surgical precautions if they do end up having a surgery. Okay, and so for prognosis and importance of early intervention, it's really important because this is really it has a silent progression. And so in early stages, like I've said before, there may be no symptoms at all. And by the time a patient feels significant pain, irreversible joint damage may have already occurred. This is why it's crucial as physical therapists to pick up their early signs and know when to refer out for imaging ASAP. And so if it's caught early enough, we can do joint preserving treatments like core decompression. And basically what that is that they drill one or more small holes into the affected bone. And what this does is it relieves internal pressure and it helps increase blood flow and allow new blood vessels to form. Sometimes the surgeon can add a bone graft or biologic material like stem cells to help with bone healing. And it's done basically to relieve pain, slow or stop progression, and basically to delay getting a total hip replacement. And so with early intervention, we can do preserving treatments like that, or also do non-surgical management to help stop progression. But unfortunately, if we do get into those later stages, then a total hip replacement would be warranted. And so early detection equals better outcomes. Thank you.